Hello and welcome to the IdeaCast interview series, episode number 138. And my guest in this episode is Dr. Sarifa Tekin, and she is Associate Professor at the Center for Bioethics and Humanities, Norton College of Medicine at SUNY Upstate Medical University. And in this episode, which will be my second conversation in a couple of years with Sarifa, we will be talking about her book that will be released. This has been recorded on April 18th, and the book will be coming out the week of the 21st, and I believe the 24th of April 2025. And the book title is called Reclaiming the Self in Psychiatry, Centering Personal Narratives for a Humanist Science. And it was an insightful conversation. We were able to talk about the work that she's done, not just in this book, but historically. And we do take a dive into the book. So I very much appreciate Sarifa for coming on and having a conversation with me. And I hope you enjoy the conversation and there's some good takeaways for you. And thank you so much for being here. I'd like to welcome Dr. Sarifa Tekin to the IdeaCast interview series. Dr. Tekin has just is in the process of publishing a book. It'll be available a few days after this recording. We're recording on the 18th of April. The book should be out and available next week. I think the 24th is what I saw on a Google search. Mm-hmm. So, and the book is called Reclaiming the Self, and I have to look centering personal narratives for humanist science. I didn't want to break up the subtitle. So welcome, Dr. Tekin. It's great to see you.
Thank you, Justin. Thank you for having me.
Yeah, and this is your second time. I'll have a link down below for the YouTube audience for our first conversation, which was a wonderful experience. And I know this will be an interesting experience. We'll be unpacking your book a little bit and understanding what your project is. And to the YouTube audience, welcome everyone. I'm very much looking forward to this. All right, so Sarifa, I guess what we could do is maybe you could give us a thumbnail of the book, what your intention was, and then we'll just, like I said, we'll unpack some terms and some ideas that are present in the book.
Sounds great. So, my book had like two basic motivations. One is, when I observe the contemporary psychiatric landscape, from research on mental disorders to treatment of people in mental health settings, there are, I don't have to repeat those. There are lots of problems emerging, and one of which seems to be there's a disconnect between clinicians and their intentions to help people. They're very motivated by, helping people overcome their mental health related issues and flourish. And patients' experiences in those clinical setting seems to be different from what doctors' intentions are. So something seems to be amiss. So in my book, I observed that one of the reasons that psychiatry, contemporary psychiatry, has not been able to quite successfully address mental health struggles of individuals is that there's a lack of focus on the self, the subject who is encountering mental distress. What I mean by this is that because it's an area of medicine, psychiatry attempts to understand mental disorders through symptoms and signs of people's experiences, and kind of, trying to understand them in a kind of more biological, neuroscientific level. But people live in their world. They have fears and beliefs and desires. They're a lot more complex than what can be alienated through these symptoms and signs. So a more robust and thorough engagement with the concept of the self would be really, really helpful for clinicians. So in my book, I basically kind of trace the roots of why the self has been neglected in psychiatry through a more historical, scientific inquiry into psychiatry's past. And I say, well, that was because there was an assumption that something like the self cannot be studied scientifically. But I argue that that's actually wrong. There are ways in which we can think about the self, the concept of the self, in a more scientifically scrutinable, in a way that would, be subject to scientific scrutiny. So, and I try to do that. I basically develop a model of the self that I argue, is going to lend itself to scientific study. In a way that is also responsive to people's first-person experiences and their narratives. And that's the way in which we can bring the self back. And if we are scientifically understanding the self in this kind of complexity, then we will be better suited in helping people kind of flourish, withstanding their mental disorders. So the audience for the book is not just philosophers, but also clinicians who are in kind of mental health related areas. So that includes psychiatrists, social workers, psychologists, but also individuals who have encountered psychiatric system or have had experiences with mental disorders. So I really hope that I can give voice to people's own experiences of their, in the mental health system, and kind of empower them to think more rigorously about their experiences in a way that will help them flourish. So, that's the kind of broad snapshot of the book.
Okay, and that's good. That and I'll give a reader's takeaway on the book. I thought, as you mentioned before we hit record, it is accessible to a general audience. It's technical, but it's also accessible, and I appreciate that. And I think your argument is well played. It's well laid out, and I will be interested to see if there's commentary about the book and what others might say as constructive critiques of the book. So I guess to maybe set some context or some groundwork. It seems like psychiatry and psychology is burdened with the task of being third-person objective, but nonetheless they're dealing with subjective agents or systems that do not necessarily fall under the same category as atoms and molecules or strings of chemistry and things like that. And so that is a hard problem for them to, it's not insoluble, I don't think, as you present in the book, but I do think it's a challenge, and perhaps that's all an artifact of the legacy of the Enlightenment project and empiricism and logical positivism and all these ideas that have been inherited, by the filial of psychiatry, the people that come in and practice it. But this is a good place for reflection, I think, in where we are now and realizing that we are not automata, we are not subjects of behavioral understanding or epistemics alone. And so the book, it indirectly addresses or even directly addresses the DSM-5. And so I'll ask a curious question. I don't sense that the DSM editions have within themselves revisions. So there's not a DSM 5.1, 2, 3. Is it going to go to DSM-6? Is this what your aspiration is, to see that DSM-6 will enfold some of the ideas and interactions that you're seeking? Is that what we're looking at, or is DSM?
Yeah, I mean that would be a philosopher's dream if actually psychiatrists and clinicians take what I say seriously and helpful in the way that the DSM revisions are done. So basically, in the current kind of schema, so there's DSM 1, 2, 3, 4, 5. And the idea is to continue to revise the DSM. So recently, for instance, the text revision, there was a text revision in DSM-5. So the idea is to have like DSM-5, 5.1, 5.2. And I think the reason that, when there's an overhaul, the number changes, that means like it's a very robust, kind of very substantial revision. So I don't think APA is there yet. I think they're working on kind of more minor tweaks and revisions. But one of the fundamental arguments I make in the book is that individuals with experiences of mental disorders are very important resources, and they would add a lot to the discussion of psychiatric classification and taxonomy. And I'm inviting American Psychiatric Association to be more open to and invite people with experiences of mental disorders to the table as kind of revisions are being done and changes are being made. So, of course, I would be very happy to see if that happens. I think APA had signaled, as I talk about in the book, had signaled some kind of reception to patients' perspectives, but they had concerns about how including patients in the DSM revision process might compromise DSM's attempt to be an objective science, right? Psychiatry's attempt to be an objective science. But in the book, I argue that patient inclusion not only is not an impediment to scientific objectivity, but in fact, I think it will make it a lot more objective than it currently is. So hopefully if they buy that argument and invite patients to the board, that would be a dream come true.
Right. And there's a lot of nuance in the idea of sacrificing from third person to second person to first person, and in the reciprocity of those three perspectives of selving, of individuality. But nonetheless, to have a view from nowhere when it comes to, again, our delicate nature, our fluid nature, and dynamic nature. That's a really hard problem to think about. But like you said, and that's the point of your book, is there's a way. And we don't have to have a false dilemma here that we can, and it's not, that might not be fair, but a dilemma that is wrought from maybe blind spots or perspectival obfuscation or whatever. So now, I guess to open up the book and to get into some of the content, let's talk about the multitudinous self and Musē, as you call it in the book. And it's multi-part. It has multi-aspectual nature. So do you want to start with Musē, and then we'll go from there?
Yeah. So it's the name of the model of the self that I develop, that I believe could be a good target in investigating mental disorders scientifically, is the multitudinous self model. And in short, I call it Muse, just the kind of
Muse.
first two letters of multitudinous and self. And I owe to one of my longtime friends and colleagues for that acronym. That was very helpful. I was in search of an acronym that was catchy and interesting, and he was like, "Well, why don't you go with Muse?" I'm like, "Oh, that's great." And also the idea of multitudinous is important. You might know Walt Whitman's poem about how I contain multitudes. In one of his poems, he talks about having multitudes and having these self-conflicting, different, complex aspects to ourselves. And that was my inspiration for naming a multitudinous self model, because I think Whitman is onto something. I think there is such thing as the self. We experience it. We don't experience it consistently, or we don't always agree with ourselves, and we don't always, sometimes have certain beliefs about ourselves that are not true. So there's this kind of intrinsic complexity in that. But what I say in this model, so when I say model, I'm thinking about how scientists do research by building models. So, I was an economist by training, and that background was actually very helpful. So when economists are trying to predict, for instance, what the inflation rate will be next week and next year, they might use different variables to create a model where they make their predictions. So in that sense, the multitudinous self model is a model of the self that highlights very salient, important, what I call facets of our experiences. So, and in that sense, we can kind of think about, and I'm sure, people might be interested in bringing in more different properties of the self. But in the book, in Muse, I looked at 5 different facets of our self-experience. One is the physical, that's very basic, right? Our biology, neurons, genes, hormones, and so on, the things that kind of give vitality and give us our flesh. That's fundamental. That's one kind of way in which we can look at the selves. The second dimension is the social self. We are, from birth, or from even prior to birth, we are reliant on other people for our survival and flourishing. We are beings with others. We are relational beings. So that's the social component is very, very important. The third component is our kind of extended, temporal kind of over time, self. And I refer to this as our narrative self. We have, we have an understanding or perception of our past and visions of our future. And we have, we tell a story about ourselves or multiple stories about our experiences. That's one way in which, we are one facet in which we can kind of get access to the self. The fourth dimension, the fourth aspect is, sorry, I'm kind of losing the train of my thoughts. I'm nervous if you could.
Oh yeah, no problem. And I have notes over here, so we can both help each other.
No, exactly.
I have strings of information.
And another Exactly, exactly. And another facet of the self is like the conceptual self, like how we, form ideas about ourselves, who we are, what kind of being, like am I confident or am I insecure or am I a social person? Am I friendly? So we have kind of certain kinds of like visions or, representations of ourselves in our minds. And what's really, really important is that this kind of multitudinous complexity of the self is embedded in a social, cultural, and linguistic world where we are in constant interaction with other selves, with the culture, like language is an important component of it. And we are, in that, like, in a particular, we are situated in a particular time. So, this model of the self that represents the self in kind of these different, representations, when you look at individual like cognitive sciences, you can actually track, you can learn a lot scientifically about these different like, facets of the self, right? For the social, you might want to look into like sociology or social psychology, how groups behave, how, individual group dynamics work, for instance, or, in the kind of autobiographical dimension of the self, you can look at like how memory works. And there are lots of scientists, researchers working on memory capacities. So by kind of looking at the self in this, like from this multi-aspectual framework, I'm bringing together existing scientific research on the self. So remember, as you pointed out, psychiatry thinks that something like the self is too subjective or too non-scientific to work with. But I'm showing, no, actually, it's not as unscientific as you might think, because there are other sciences that could look at these different aspects of the self in a kind of more scientific, empirical way. And another aspect, another kind of important, part of the like paradigm of Muse, multi-unit self model, is that each of these facets respond to our experiences more or less, right? Like every single person in the world, I'm pretty sure, they all have like physical bodies and they all are part of these social communities. They all have like autobiographical, like, experiences and narratives that they tell about themselves. And they have they have ways in which they perceive themselves. So in that sense, I think the multitudinous self model is getting something kind of generalizable and universalizable about, what it means to be human.
Mm-hmm. Going from a flat ontology.
So that's basically the kind of the sketch of, sorry?
Oh, no, I was just a little commentary that we're going from a flat ontology to a multidimensional ontology.
Exactly.
With your, or muse. I had to get out. I call it muse because I didn't hear you say muse, so sorry.
Muse, yeah.
Muse.
Yeah.
I love that too. Yeah. I'm sorry, I disrupted the train of thought a moment ago.
No, that's good. There's like a lot to keep in mind. I was, when I was doing the proofs of my book, like I'm just reading every single line and every single word. And, I'm like, oh, wow, like that's a lot. Like, let me kind of backtrack and reread that section again to remember how it was connecting to the whole book. So it's a, complexity. I aim the book to be accessible, but I think, it's accessible, but it's also a little complex. There are parts of it that are complex.
Oh. Well, we're dealing with deep abstraction when it comes to mindedness and agency and selfing and things like that. And I like, and I'll add to what you just said, in my takeaway that, you state it in the book that you're agnostic about what self is. And I love that because for myself, and I'll do a little self-centric analysis here. Self to me, I lump it with kind of like consciousness that it neither is or is not, and it's I see it more as a verb rather than a noun. Mm-hmm. It's not something you could kind of reify propositionally or objectify in a sense. You have to sometimes for I don't know, heuristic models or whatever, but I think to liberate self, it is that selfing occurs and selfing is fluid, and to reify a self is maybe going down the road of identity and ego and persona and things like that, whereas that the, like you said, the muse or the multitudinous self is flexible, fluid, dynamic, changing, and it is contextual. It is bound by social context, by cultural context, by situational context and environmental niche type context. So that you do that, I think, gives it a dynamicism that can then penetrate this again, I don't want to call it a false dilemma, but this kind of dilemma that needs some remediation, maybe, you know?
Yeah, no, exactly. I mean, the self is a fascinating subject matter, and, you know, like you can trace different disciplines' own histories of the self, right? Like there's like the psychological self that we see, you know, in the works of like people like William James, you know, that, attempting to kind of talk about the concept of the self in a more, you know, empirical way. Or like, you know, there are, of course, like psychoanalysts like Freud, who had like, you know, his own conception of like what the self is. And there is a philosopher's self, right? Since the ancient Greeks, that we have different ideas about what it means to know oneself, or, you know, as, you know, we come to Descartes in the more modern area. So he's trying to reconcile the mind and the body. I mean, and that metaphysical kind of work on the self is very interesting. But because my goal was kind of to think about mental disorders in relation to the self, or, you know, in relation to this, you know, thing that we call the self, I was hesitant to adopt any kind of a metaphysical, notion of the self, because I think I would think that my Muse model, it can accommodate different kinds of metaphysics of the self. I haven't developed that in the book. But again, because my goal was, you know, that's just to kind of to get at the experience of mental disorders, because one of the things that, I think is when we think about something like mental distress or mental disorder, I make that distinction in the book. There are ways in which to talk about those disorders or distresses in relation to those different aspects of the self. And it's often the kinds of conflicts that happens, right? Like, you know, socially, you know, you might be very well loved and well regarded and so on and so forth. But in the kind of experiential domain, you might not feel that. You might feel like you're lonely and so on. And part of mental distress emerges when those kinds of conflicts and incongruences occur. And if you want to get at the root and address those kind of sources of distress, then we have to really engage with the kind of this more, empirically rooted conception of the self.
Yeah. And again, the metaphysics aside, like you said, it can fit itself to, except for maybe some of the outlier theories, but, you know, standard, accepted, not terribly controversial ideas of what a grounded, you know, metaphysically definable self is, which again, I almost, as I said a minute ago, I almost parallel it with the debates in consciousness and studies of consciousness, where we're either eliminativists or we're saying everything is consciousness. And it's like, again, that's reifying it as an objectifiable thing. And I would say, well, maybe not. Maybe it's, you know, as we are limited cognitive systems, that we develop language that is exclusive to ourselves. And we have to, and of course I'm being very arrogant in saying all this, because a lot of people have poured incredible amounts of thought into this. And this might be a good segue, because one thing, to speak to consciousness for a moment, you extracted something from Dan Dennett's work, and that is the intentional stance. And then you modify that in the book to a medical stance. So that might be a good thing to also bring on board in terms of some of your terminology, and how it helps develop your system as you move through the book. So can we talk about the medical stance,
No,
but first
absolutely.
maybe the intentional
Yeah,
stance?
absolutely. So, the listeners might already be familiar with the concept of intentional stance that's developed by Dan Dennett, but I'll just kind of, highlight what it means and how it's important for my project. So, Dennett was a great philosopher, I think, who kind of helped us understand our folk psychology, our regular kind of everyday human psychology a lot better. So, because one way to think about, how humans work is to look at their genes and like kind of more reductionistic approaches. But he was like, no, let's like look at, how people actually operate, how social cognition works, how we interact with one another. And one of the things that he says is like, there are different ways in which we can explain phenomena in the world, right? Like, if you want to understand like, how the flight will take off, you might kind of adopt something like he calls like the design stance, right? How the different parts of the machinery of the flight of the planes put together, and how they, take off and so on and so forth. There's also like the physical stance. You can kind of explain, certain phenomena like in the world by just kind of looking at its physical makeup and so on. But when it comes to human beings, and he says, it's usually safe to, if you want to predict somebody's behavior or understand why they have done the thing that they've done, you adopt what he calls intentional stance, that you assume that the agent in front of you who's acting in a certain way has beliefs and desires and has all these mental states that he acts like accordingly. Right. So if you want to understand like why, I might be, getting ready right now, and you look at me and you might say, oh, like she has to teach in a couple of hours, so she's getting ready to leave for work or something like that. Right. She wants to she wants to make it to class on time. So she has like certain beliefs, desires, and plans about like her life. So, and I think, I really like that kind of, conceptual framework of like attributing intentional stance. And in the book, I talk about our attitudes towards ourselves, like how we interpret our own mental states or our own behavior and experiences. And, I use the concept of medical stance, to describe understanding our experiences and behavior through the lens of medicine. So what this means basically is this. So let's say, you really, really do not want to go to work this morning, and you just don't want to leave the bed, don't want to get out of the bed or whatever. There are different ways in which you can kind of think about your particular mental state at that point. Like, why do I not want to go to work and stuff? Like one thing would be, I'm really, really tired. I need more sleep, right? Another thing might be like, oh, there's so much work at work and I really want to avoid it. But then another thing that you might say is like, well, I'm really depressed, right? And so like saying that, calling yourself really depressed to explain your lack of desire to go to work would be an example of adopting a medical stance, where you use a medical framework, a medical like diagnostic label to kind of make sense of your own behavior. So, and that's kind of like how I think about like the medical sense, because an essential part of thinking about the self in the context of psychiatry is how individuals with diagnosis of mental disorders understand themselves. And I highlight how the diagnostic label can sometimes be used in people's ability to make sense of what's happening in their lives, and they might adopt a medical stance to explain certain phenomena. Like, my husband left me because I was depressed, or, I was fired from my job because, I was depressed, right? Like it kind of can serve as a shortcut, a form of explanation in, making sense of your encounter with mental disorder.
And in developing that, this is going a little further along in the book, but one thing that you point out as a critique of not perhaps the DSM, but psychiatry in general, is there's something you mentioned called the twin failings of psychiatry. And maybe we could open that up, because that brings in hyponarrativity. And I think hyponarrativity, as I understand it in the book, is twofold. It is, two different systems. There's a system of psychiatry that will address, and perhaps also the patient themselves in their medical stance that they take that you just described. So if you want to unpack that.
Yeah, exactly. So the first part of the book is criticism, right? I'm observing what's out there and what's happening, using first-person reports of individuals who have been part of psychiatric system, as well as like history of, psychiatry, and, looking at psychiatry's main documents like the DSM or the RDoc and so on. And the second part is the positive proposal. Like, so I identify certain problems in the first part and try to solve them in the second part. So, when I say, part of that critical framework is what I call psychiatry's twin failures. So, and twin failures are this. So on the one hand, psychiatry, has not taken the concept of the self as a scientifically, grounded phenomena or target that should be studied in order to understand mental disorders. So psychiatry misses the concept of the self. Like that's like one failure. And the other failure I identify is that at no point in history of psychiatry, patients with experiences of mental disorders have been considered as reliable sources of information that can illuminate our understanding of mental disorders. So at no point in history, patients have been regarded as, full agents who can say things about their experiences in a way that will actually benefit scientific psychiatry. So those are the two twin failures. And then, in the kind of second part of the book, I talk about how psychiatry can bring the self in both these ways, like how it can study the concept of the self in a more explicit way, in a scientific way, and how it can make individuals with encounters with mental disorders part of psychiatric science, like how to do science with individuals. So, and that's the twin failures, right? And you were asking about hyponarrativity and how that connects to medical stance. And so one of the ways in which I kind of talk about, so the twin failures are not just kind of failures like for their own good. And I talk about how they have led to some epistemic and ethical costs, right? Like what were the consequences of not studying the self explicitly in mental health care, or what are the consequences of not giving uptake to patient experiences in the clinic? And what I say is something like this. Look, when we don't study or think about the complexity of the self in this kind of research scientific framework to understand mental disorders, and we train, clinicians with that kind of a limited framework, right? Like through like signs or symptoms or other maybe more kind of reductive explanations of mental disorder, we don't end up training clinicians to be prepared to actually have patient encounter, like to help them. Because, again, like I'm in a medical school now, I teach a lot of psychiatry residents, I teach medical students. Everybody really wants to help people. Like there's no bad faith. They're going through all of these like intensive like schooling, years and years of schooling to go and help people. But my worry is that they may not have the tools to really be present with the patient and engage with their whole complexity of the self. So, and that's kind of one way in which that, twin failures can be costly, because we're not really teaching or educating clinicians with the kind of about the complexity of the self. Another way in which is because these, most of the psychiatric frameworks like the DSM are used in context other than clinic, right? Like for insurance purposes, for administrative purposes, determining kind of like the curriculum, school educational curriculum. They have like things like the DSM has a lot of power. So I call this the DSM's institutional and cultural power. Not only, anything about mental health is managed by the kind of this DSM framework, but also when you Google something, right, the first thing that pops up is all the DSM's, symptoms and signs. And DSM never actually intended to be used in like a kind of this, like in the Google your symptoms way. Yeah. It's so available and so easy, right? So, and sometimes, right, patients, individuals with encounters of mental disorders or encountering some kind of mental distress, they go online, they look, and they start thinking about all of their life experiences through the lens of an illness, as opposed to maybe part of your transition from teenagerhood to adulthood, right? Like we have different life transitions, and life never, goes smoothly or moves like, we're not ever the same thing. We are always going through transitions. And I talk about how individuals, to make sense of their life experiences, sometimes use medical stance. And that can, maybe be helpful in some ways by, maybe helping you decide that you may be in need of medical help and so on. But it also has like kind of some possible negative impacts where you think of everything that is actually part of your human nature as if it's an illness, and that has its dangers. So, and that's kind of how so to be scientific, to be easily, usable, DSM is like hyponarrative, where, hypo means, little, right? Like there's a small narrative. There's a small narrative about your experience in terms of like signs and symptoms. Like you might have lost your appetite. You may not have been sleeping well and so on. And that's a great, actually, kind of a framework to get started. But sometimes people associate with that hypo narrative and forget their larger, more complex life narratives, right? Like, oh, maybe you just started college, right? Like, let's think about the distress that you're having by thinking about, your first time in college, you're away from your parents, and, maybe it's not actually an illness. It's, it's like your life transition. It's a challenge. And I think this kind of hyponarrative framework is, robbing people from different ways of conceptualizing or thinking about their experiences. And I want to highlight that I don't think, and it's very clear, I think, in the book, that this is not the DSM's fault. Like, DSM is not, APA, American Psychiatric Association, is not out there to tell people, okay, like, I want you to think about yourselves in these like narrow ways. But that's also part of, our kind of cognitive architecture. We are beings that seeks for reasons and explanations, and we want those explanations as easy as possible. And these, broad frameworks work like good kind of fathers to do that. And for that, I bring in some research from psychology about like cognitive biases and how our, reasoning is intrinsically biased and always biased. And, it kind of creates this perfect storm when it comes to, easily available frameworks. And that's why I think turning the attention to the self or the person, even in the clinic, would be really helpful, because, ideally clinicians know this about human nature. And they can be very explicit about what exactly a diagnosis means and doesn't mean, right? Because, again, DSM is just a sketch of mental disorders. We formulate these categories to just get best at the thing that we're trying to get at, but it's subject to revision and change. That's why the DSM keeps rising, because, the idea is like, well, as we improve our science, we will better be able to understand mental disorders. So these categories are not fixed things. But I think that gets lost in translation. I worry that a lot of patients in clinical settings really take that as final and irreversible and unchangeable as some of the other kind of physical illnesses that are out there.
Yeah.
So that's the kind of broad summary of the twin failures, hyponarrativity, and medical stance.
Right. And you brought up the fact that there are people out there who will not malfeasantly use the DSM inappropriately. It's just, and there are people who will use the physician's desk reference for, contraindications if their recreational drug uses,
Exactly.
if they're trying to be smart about doing drugs. So, every good, well-intended book that is, a Bible of information for that particular discipline, and it can be even the police detective's handbook can be. And I've seen them.
Absolutely.
Complete
Yeah.
So
exactly.
we have to just acknowledge that there's downsides, I guess, in the social commons when things are introduced. And you address that to good effect in your book. I know you cited a couple of case studies, I guess, or situational observations of people who do that, young people especially with the TikTok age and all this kind of stuff. Yeah. And they go in and they say, "Oh, I'm presenting," like it's a. That's like,
no, and that's an interesting phenomenon. So the individuals who self-diagnose and come to the clinic are always, they're a tough audience. They're a tough patient group to treat in some ways, right? A lot of clinicians roll their eyes the minute you talk about a teenager self-diagnosing themselves with a mental illness of some sort on TikTok. But I'm inviting to be a little bit more humanistic about the way in which we approach people who self-diagnose or, who might go on social media to do that. And I'll try to kind of explain why is it that they might be doing that and what are the ways in which we can help them, because self-diagnosis can also be very beneficial. Like I have, there are individuals whose, autism diagnosis was never made as a young kid, and now as adults they are diagnosed and they are able to get accommodations, and they have a better access to kind of themselves in some ways, and that happened only because maybe they realized, do you think maybe I have this, and then they seek a clinician's help and so on and so forth, right? So but at the same time, right, like, and it's informing, I think, providing information to individuals about like psychology or human psychology is just an essential step prior to coming up with a diagnosis and so forth. I mean, when I see those teenagers, I mean, teenagerhood is at the time in your life that you are trying to create an identity for yourself. You want to be socially accepted. You want to stand out, from like other people, your age group and so on. And you're kind of this like, you're in search of some kind of meaning and identity, and you're trying to come to yourself. And in that process, you experiment with a lot of things. And I think maybe some of these like self-diagnoses or this kind of in these public social media platforms is one way in which trying out, like what might be happening, or it might be a genuine cry for help, right? Like, and I think we're seeing that more and more. I've actually recently turned to studying teenagers. I think that might be my next project, because I'm really fascinated by like, the ways in which one tries to kind of, make themselves or whatever. And, social media is a kind of a, interesting platform. So that's like, I call this, the TikTok problem and the self-diagnosis problem, and think about how Muse, like my model of the self, can help us engage with this individual in a way that will help them. And that's the other thing that I should kind of, I guess, highlight. When I think about like psychiatry or psychiatric treatment, mental health treatment, I'm more interested in getting people to a place where they flourish than I think fixing their illness or remedying their problems and so on. I have a more kind of a, I think it's totally plausible to have mental distress and disorder and flourish at the same time. So I think focusing on the kind of the broader complexity, multidimensionality of the self allows us to do that a little bit better, rather than this kind of a purely medical framework of you either have this or don't have this kind of understanding.
Mm-hmm. Mm-hmm.
Yeah.
I'm really encouraged that you mentioned that your next pursuit might be that of understanding this phenomena with teenagers, because it's something that concerns me, and it's a little pet. This is a little tangent, so forgive me, but as an aside, it's interesting. I'm noticing with Gen Z and younger Gen Y or millennials, that we see avatar and prophylactic selfing becoming more pronounced in the psychic profile of an individual. And I've been following the work of Hans-Georg Moeller and his lineage with Niklas Luhmann and Gita Bord and McLuhan and a few of these other social systems people in media theory. But I think it's nonetheless prescient that we focus on that as a culture. Because I'm old, I grew up without all that, and so I can see it from another position. So just the tangent, just to say,
absolutely.
I would be looking forward to your work.
No, thank you. And I've been working on AI and the use of AI in these like psychiatry settings, and it actually really intersects. But most of the, I mean, there are teenagers who use these kind of AI agents as, friends or therapists or conversationalists, and which resulted, with some of them committing suicide and self-harm and so on and so forth. So I think that's a very, very important topic. As you said, I think, you probably and I are in the same generation. Like, we have an understanding of the world without like the internet or AI or all of these kind of like online presence. But it's a different kind of world right now. And I think it's really important to take the time to try to understand what might be happening and what is actually helpful for our humanity and what is not. So Yeah,
Yeah.
I'm looking forward to my next project too.
Good, good. Yeah, they have so much more of a stronger a posteriori grip of that reality than I would. I can immerse myself in it, and
Exactly.
from my position, I can hopefully be less pathological because I'd love to have a bot that can talk to me, and but
Hmm.
I would perspectively, be aware that this is not true, or it's a simulacra, it's purely
Exactly,
simulacra.
exactly,
So,
exactly.
um, now, going back off my tangent now, and thank you,
Yes.
is to go back to what you were saying about the twin failings and so forth. You are in medical humanities, and you are deeply immersed in a STEM environment where people are learning. There are med students. How are you being received? Are there camps? Are you finding that you're being well received in this approach to humanizing
Mhm.
our approach to the living system that is one of us, human beings?
Hmm. Hmm. I'm fortunate to be at an institution that actually has a center for bioethics and humanities,
Okay.
and we do a lot of teaching in the medical school and in the residency programs at Upstate, and also we provide the ethics consultation service for the hospital. So actually, I'm in a context where people care about what I say as a humanities person, and they care about my ideas and so on and so forth. But of course, like there's like this kind of, I mean, years of ways of educating physicians that is very, very, very STEM focused. And to the extent that humanities and bioethics and things like philosophy get into picture, they're, time wise a lot like, a lot shorter, right? Because I mean,
Hmm.
they really do have to get through a lot of like STEM related material. But also I think, maybe medical school or even like residency is also a little later. I mean, they realize that they need this human side of medicine, and like residents take it very seriously. They ask questions. They genuinely want to kind of have a better grip in approaching their patients in the clinic or try to help them, and they appreciate the humanities. But I think when you look at like general education system in general in the United States, like things like philosophy, sociology, psychology, they come in quite late in college, and not every student ends up taking these kinds of courses. So, and I think not just for people, medical practitioners or whatever, I think we need a more robust education on like human psychology or philosophy, even at the elementary, secondary school level, because I think one of the reasons that, especially around teenagers, there's this kind of direction towards medical frameworks is that there are not many alternative frameworks. I mean, there are not many like well-being classes, right? Like, how do you
Hmm.
take care of yourself? Like, just basic, like, not just your, physically, like, we emphasize exercise and, nutrition maybe a lot more, but like, what about psychological health? Like, what are the things that we ought to do to, maintain like good, like psychological, like a good, healthy psyche? And I think, and that's kind of, again, my push for thinking about the self is motivated by these kinds of like, I guess, reforms in our, education systems, or how we, think about mental health in general. Unfortunately, a lot of mental health talk is squeezed in mental illness talk. So I
Hmm.
want to kind of reverse and think about mental health, well-being. And actually, there's a lot of great philosophical work being done now in the area of like well-being, that I'm really eager to kind of connect more directly with what I've been doing so far. So I think that we need more of those, and kind of even in very traditional areas of medicine, like in internal medicine, for instance, there's a move towards thinking about human beings in more complex ways. There's a lot of attention being paid to like psychosocial determinants of health, and those kinds of issues. There's more, I guess, a medical humanities kind of approach being developed, and I really hope that psychiatry joins that general trend in the rest of medicine to think about human beings more holistically when thinking about their mental disorders.
And I'll ask a question about how you're received by peers and by people in the profession. But yeah, when it comes, it almost seems like there's a performative contradiction arising when we are again, third person objective, kind of, I would say, sterile approach. And the objective or the ends sought are that for human flourishing, well-being, eudaimonia, all those things. And so to inject this kind of thinking into a STEM heavy, empirically heavy environment, only makes sense because, we are affective creatures, and to make social commentary for a moment, I think we chase hedonia far more than we chase eudaimonia. And hedonia to me is not well-being. It is not, the flourishing that we may actually need as living systems. And to focus on more of a eudaimonic ends and flourishing and well-being in that regard, rather than just, high dopamine hits and, elevated affective valent, blah, 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 that what you're proposing facilitates a move in this. I could be totally biased and dogmatic in thinking this way, but just that we move into a direction where we recognize what flourishing is and how do we incorporate objective third-person science, STEM-oriented thinking to that which you and your colleagues are manifesting. So it's not kind of a commentary. And if you want to respond to that,
true.
Yeah. But so how are you being, this book is just a chapter of your work. And historically you have endeavored to these ideals. And so how are you being received, and are you receiving good, input, review, peer review, and all these things? How's that working for you with the
Yeah, no, it's actually been, it's been a lot better than, I feared it would be, as you can imagine, writing a book is, a lot different than, writing like articles, right? Like there's a kind of, a lot longer process, a lot more, many like peer reviews and, you have to kind of pass a lot of tests and stuff, but it's been quite positive. I'm actually really happy. Obviously the book is not, is going to be out next week, and I'm sure I will get more reviews and stuff in official like platforms. But there's already there was a author meets critics session at a conference a few weeks ago. I have a book workshop that people have organized in Montreal. So like there's a lot of opportunities for me to interact with the critics, and it's been very positive so far. I think the philosophy, my field, has been getting a lot more open for to do interdisciplinary research, or especially in the area of philosophy of science. There's this kind of now, movement to engage with the scientists or the science that you're doing the philosophy of. So I'm part of that tradition. And in that sense, and I think the kind of work that I've done with psychiatry, just looking at it as a scientific enterprise and so on, has been really welcome, because then I'm able to use a lot of the debates and conversations and the kind of, build, accumulated knowledge and philosophy of science to apply it to certain questions like objectivity in science and so on and so forth. So in that sense, that's been, people have been really supportive and enthusiastic about the project. And also there has, again, traditionally, philosophy talks more about thought experiments or, these hypothetical scenarios or cases when it comes to doing philosophy involving minds, right? Like we imagine, that you're able to, fission or fusion. There are all these like very interesting, I think, thought experiments, right?
Right.
But my methodology is actually turning to real people, talking about their real experiences, using their own words to describe who they are and so on. And that's also been quite welcome. I got like a lot of positive remarks on that methodology about how it's kind of, doing more grassroots philosophy rather than kind of thought experiment like philosophy. Not that there's anything wrong with that approach, but it's just different. And I think philosophy is an amazing field where, depending on what you want to do, sometimes thought experiments can be extremely, extremely helpful to get across an idea. But if your interests are in an area like mental disorders and so on and so forth, it makes a lot of sense to actually look at people with encounters of mental illness. So it's been positive so far, and I hope it continues that way. And there's a long tradition again in philosophy on the self and self-knowledge literature. So there are some questions about how reliable first-person testimonies or first-person reports are, which I kind of take as like a primary ingredient in my work. But I also address these challenges in the book about how, reliability of first-person reports, whether they matter or not in the context of like treating people with mental illness and so on and so forth. So it was, the kind of the author meets critics session that was held for the book was actually very enriching because people kind of brought different kinds of philosophical arguments to engage with some of the things that I was saying in the book. So it was very enriching, and I hope it continues the same way. I'm very curious to hear how clinicians and psychiatrists will receive it. I'm part of a very interdisciplinary community, and there were lots of clinicians and psychiatrists that I interacted with, and we're actually mostly in agreement even with clinicians, because when you talk to a clinician, they resent that they have to use the DSM or give someone a diagnosis so that they could get insurance coverage for their, health expenses, right? Like that's, that kind of limits your freedom or your ability to really, engage with the patient. If you have to kind of abide by this, institutional structure and frameworks. I think, especially on those kinds of themes, there was a lot of positive enthusiasm. But I'm curious whether the Muse model will be considered as an effective, kind of helpful clinical and scientific research tool. So we'll see. Time will show us.
Absolutely. And again, me being kind of naive street level person, I can't help but think from my perspective that if one is willing to accept observation of someone in psychosis, and you see repeatability of patients presenting psychosis, and granted, you can have a consortium of people or a group of people that can observe psychosis outward or from an extracted or outward perspective, that to go into the interiority of the experience. And I feel like we brought up the plural of anecdote as data in our last conversation, that if you qualify things and sift things out a little bit, that in the repeatability of what people are telling you of their affective state or their what they're presenting, to me is almost equal or synonymous with what a fallible human being who is loaded with their own perspective biases or whatever as a clinician, regardless whether it's 15 clinicians or one clinician, they can all kind of, so there's fallibility in all of that, I think. But,
exactly.
Right. So to out of hand dismiss that group of people in psychosis, and sorry to pick on people with psychosis, but it could be anything, whatever you're presenting, this pathological, I just, as an intuitive person, it just strikes me that, with caveats, with a lot of, asterisks at the end of the statement, that you can extract from some group of people, a cohort or whatever that are presenting something, that there's repeatability there and there's reliability in that repeatability, and that it can be harvested and harnessed.
Yeah, exactly. And like in the book, I'm very clear about how to arrive at like an objective kind of how to make psychiatry an objective form of inquiry. And what I say is this: look, we will have scientists who have been educated and doing research on these topics. We have clinicians who have years and years of experience of seeing different kinds of patients. And we also have patients themselves who have either been experiencing these, phenomena by themselves, or having, observed other people in their community with similar experience and so on. So all of these different standpoints or different perspectives actually enrich our knowledge. And in that kind of, I'm a big fan of criticism, critical engagement, right? Where, I think we need to sit at the same table, as scientists, clinicians, and patients, and talk, right? Like engage, what are the disagreements? Because I imagine that there will be kind of a lot of agreements, about certain phenomena, and there will be some disagreements about some other phenomena, but there are, I think, ways to engage and hash. And if we make that process of doing science objective by including different perspectives and different standpoints into the discussion, I think that will, result with knowledge that is a lot more grounded and objective and helpful for people, who want to know them. So if you're a neuroscientist, for instance, so just studying the brain and maybe trying to understand the dementia and like how the lesions in the brain form and all of that stuff, you may or may not need to interact with the patient with like Alzheimer's, right? Like that might not be, particularly helpful for your like little neuroscience, like, that project. But if you're a clinician, who care about, how you actually treat this particular patient, then you want to have access to that first person, wisdom, to kind of facilitate maybe your clinical treatment plan. And that's kind of, and those are the ways in which I think the book is, saying, well, I'm not saying just trust the patients or just like only listen to the patients or only listen to the science. Look, we need everyone. We need like platforms to talk and that's my biggest, again, kind of like observation. It's changing, though it's very, very slow, but usually, individuals with encounters of mental disorders and distress organize amongst themselves. And then there are clinicians, there are scientists, and everybody goes to different kinds of conferences. So there are not that many platforms or journals, right, that bring all of these different standpoints into conversation with one another. So, and I'm trying to build that bridge through this book. Like, look, we need everyone. We need everyone, and we need to kind of set some ground rules for discussion and conversation and actually engage with these different ways of knowing and experiencing the world, if our goal is to really help address the problem.
Yeah. And I think the discipline does not have to worry about any kind of zero-sum problem scenario, because they can bring all of their rigor to bear that historically they've housed, but also bring, you talk about an intentional stance, bring the a posteriori stance versus the a priori stance into the fold. It won't poison the well if it's done right and with the empirical rigor of selection and repeatability and all these things. And again, I think that's there as just a hoaxy intuitive guy.
And when you look at actually these, like, when you look at smell research, for instance, right? Like, and smell is as subjective as something that can get. There is like smell science. Like, there's a scientific way of engaging with, people's differing sense of smells or, sensitivity and so on and so forth. And some of that work had been very relevant and useful to understand COVID-related smell loss, for instance, right? And in that process, there's like several studies and like published, like including philosophers, where clinicians and patients and philosophers came together to write about or to think about, sense of like smell loss in the context of COVID. And that was because, patients were very involved and interested in understanding this thing that was happening to them. Like suddenly they had COVID and they lost their smell, and that's affecting all parts of their lives and so on and so forth. Another example I give in the book is, HIV research, back in the, in the heyday of the HIV, epidemic. There were, people were dying, left and right. There wasn't a lot that medicine was able to do. Drugs had to be developed, research had to be expedited, like fast, to address like that population. And it was primarily those patient groups themselves, like they became activists, advocated for themselves and pushed, researchers and clinicians to try like new drugs or, like engage in different kinds of research projects and stuff that was very helpful in, now, like, HIV, having an HIV virus is no longer the, like a death sentence, right? Like people learn to live with that. And when we look at that history of that research, and that's science, like that's like, it's not non-scientific, but it was patients or individuals with the experience were at the forerunners. And I don't see any reason for why psychiatry would not be one of those scientific areas where patients have, and even a cool seat at the table that to push research. So, and we're seeing a little bit of that with the, autism community, and their advocacy, helped generate, some changes in the DSM frameworks and so on. But, I think, we need a broader openness and acceptance, of patient, testimony and the value of their, insights and reports to advance psychiatric science.
Absolutely, and amen. And we've come up on that amount of time that we agreed that we would allow for this conversation, but I don't feel like we did your book enough justice. There's so much richness in there, but I think this is good in a way because then the audience member can feel the lure of the book and go check it out. So I would advocate for that. If this is your field, if this is a field of interest for you, whether you're someone dealing with mental health issues, or you're a clinician, or as you said, a social worker, psychologist, anybody that's in this domain, I think this is a valuable and a rich resource. And I very much enjoyed reading the book. It was informative, helped bring me up to speed on some ideas, as especially your thesis that you're working with here, and trying to get it to penetrate, something that's probably a glacial process. And so I will be your cheerleader advocating. Before we, oh, you're welcome. Before we say goodbye, was there anything, again, not having covered the fullness of the entirety of the book, but is there anything you'd like to conclude with before we check off out of this?
Yeah. I mean, I guess like one thing that I would like to say, I really love dialogue and interaction. And I want to say very clearly, like, look, this is my first stab at kind of, solving or addressing some of the kind of perennial issues that psychiatry and mental health has been dealing with. And I'm very much looking forward to feedback and ways of expanding my views, or, or even challenging them, because, there might be some blind spots and so on and so forth. And that's why we we need the dialogue. And I really, really hope that this book becomes instrumental in bringing people from with different kinds of expertise when it comes to mental illness and mental health together, and so that we can kind of talk and learn from each other. So thank you so much, Justin, for hosting me, and this lovely conversation.
Oh, well, thank you for being my guest. And as I said before we hit record, I'm humbled that you came back and wanted to have a conversation with me. Because again, but we then acknowledged that there is a need for bridges to be built from technical language and complex abstract ideas down to sort of a social commons area where we can digest that. And so hopefully we did a little of that today. And to the audience, the book is accessible, it's digestible for anyone who's interested. And you just have to be curious and interested in the matter that's being discussed, and the rest will take care of itself. So yes, thank you, Sarifa. I appreciate you being my guest, and you're always welcome to come back. So when you're crossing another threshold into something new, like perhaps the work on teenagers, I would definitely love to have you back, because I consider that an existential issue for our next generations coming behind us, so or with us, or however you want to say that. So I will say goodbye to you after we stop record, but to the YouTube audience, thank you so much for your time, attention, and attendance. All right, take care, everyone.